students, hope you are all doing good. In this video, we are going to discuss about medical termination of pregnancy. Okay, so medical termination of pregnancy, that is about induced abortion. Okay. That means termination of pregnancy either by medical methods or surgical methods. Okay. Now we'll see what are the indications or what are the grounds for MTP first. You can remember these criteria as DAS. Okay, THE, the S. Okay, so it is T means therapeutic grounds. Okay, that means when a woman is going to continue her pregnancy, that is endangering to her life itself. Okay, so when woman's life is endangered due to pregnancy. Next is H. That means humanitarian grounds. Especially in the case of rape. Next is eugenic grounds. Okay, that means when there is a risk to the fetus. Okay, suppose if the fetus has a chance of being born with a physical or mental abnormality, then also MTP can be offered. And next ground is, that is yes, that means social grounds. That means when there is a pregnancy that has arisen out of contraceptive failure. Okay. Okay. So if you see, there was an act called MTP Act. Okay. So actually it was first passed in 1971 and it came into effectiveness from 1972. Okay. So after that there was one change in 1975. Okay. So a revised MTP Act was released in 1975. And there is one recent MTP Act, in 2020 also. Okay. And there was recently an MTP Act passed in 2021. Okay. Now, this MTP Act defines the indications of MTP, the gestational age till which MTP can be performed, then who are the persons qualified to do the procedure, and who should give the consent, and the place at which the MTP can be performed. Okay. Now we'll see one by one. First one is indications. Already we have seen the indications. So, whenever there is risk for mental or physical health of the woman, yes, when there is a risk to the fetus, okay, that is the child is born physically or mentally ill. Then the pregnancy arises out of rape or there is a contraceptive failure. Okay, and we will see the gestational age. See, previously they were allowing MTP till 20 weeks only. Okay, now since this act has passed, we can perform MTP till 24 weeks. Okay, so up to 24 weeks. So, in less than 20 weeks, opinion from one medical practitioner is enough. Okay. And when it is performed between 20 to 24 weeks, then opinion from 2 medical practitioners is necessary. Is needed. Okay. And if we see the persons who are qualified to do MTP, these persons can have a degree or diploma in obstetrics and gynecology. A person who has completed six months of residentship. Okay. So it is 6 months. 6 months of residentship in obstetrics and gynecology. And who have at least 1 year experience in the field of obstetrics and gynecology. And he should be worked in a hospital which had all the facilities for MTP. Okay, hospital which has all the facilities for MTP. Okay, and this is especially up to 20 weeks of gestational age. Suppose if the fetus has been identified with substantial congenital anomalies, then this upper limit of 24 weeks will also not apply. Okay, that means you can do MTP till any weeks of gestational age, and in that situation you need a opinion from a group of members. Okay, that should include a gynecologist, a pediatrician, a radiologist, and any other additional specialty doctors if needed. Okay, so MTP can be done even after 24 weeks if there are severe congenital malformations in fetus. Okay, that time you need a team of a gynecologist, a pediatrician, a radiologist, and any other specialty members if needed. Okay. Okay, now we'll see about the consent. See, according to the recent act, only if the pregnant woman gives consent for MTP, that is enough. Okay, consent from the partner is not necessary. The consent from the guardian is important only when she is less than 18 years of old. Okay. Only the consent of pregnant women is required. So, only less than 18 years means, or if she is mentally ill also. Okay. In these cases, a guardian opinion may be needed. Okay. And the consent is obtained according to the form C. Okay. And remember, it can be performed at places that has been approved and maintained by the government. Okay. The places where it can be performed include the hospitals which is maintained and approved by the government. Now, in this act, the term married woman and her husband has been replaced by married woman and her partner. Okay. There is also privacy protection in the Act stating that the woman who has undergone the MTP Act, the details of that woman should not be enclosed to any other persons except some persons who are authorized by the law. Okay. Now, let us see the difference between the previous MTP Act and the recent MTP Act. Okay. That is MTP Act 1971 and MTP Act 2021. Now, what are the indications? Okay, indications also includes contraceptive failure, and in the previous act only married women were covered. Okay, and recent act covers the unmarried women also. And the gestational age limit is another difference. Previously it was allowed till 20 weeks of gestational age. Now we can do till 24 weeks of gestational age. Now, regarding the opinion from registered medical practitioners. So, medical practitioner opinion. See, up to 12 weeks, okay, up to 12 weeks, what opinion from one RMP is required, and from 12 weeks up to 20 weeks, opinion from 2 registered medical practitioners are needed. Okay. Whereas here, up to 20 weeks, 1 registered medical practitioner, and from 20 to 24 weeks, 2 registered medical practitioner. In case if you are going to do MTP after 24 weeks, then a medical board opinion. Okay. Suppose there is a breach of confidentiality of the women. In the previous MTP Act, there was a fine of 1000 rupees to be paid. But in the recent MTP Act, it is fine and imprisonment up to 1 year. Before planning MTP, a pre-abortion counseling should also be given to the patient, in which you have to discuss about whether the MTP is needed or not, and what are the methods of MTP available, and which will be the most suitable mode of MTP for the patient, and what are the expected complications after MTP. And after completing MTP, she should be advised about the contraceptive and sterilization procedures also. Okay. So pre-abortion counseling is important. Number 1, to decide whether termination needed or not. Okay. Then to decide on the options for terminations. Then to have a knowledge on the expected complications. Then to counsel her on contraceptive and sterilization choices. And also, before you start with the MTP procedure, there should be a proper history taking and a general examination of the patient, as well as you have to make sure about the gestational age of the fetus by doing a clinical examination or an ultrasound examination. And some basic investigations like hemoglobin, hematocrit, blood grouping, blood typing, and then if needed, the serology should also be sent. Okay. So first we will do history and general examination of the patient. Then we'll confirm the gestational age by doing a clinical examination and most commonly by ultrasound confirmation. And then you have to offer her investigations like blood grouping and typing, and then serology. Okay. We'll see the methods of termination of pregnancy trimester wise. First we'll see first trimester. In first trimester, you can offer her medical method of termination or surgical method of termination, which means a suction and evacuation method. And previously, menstrual regulation and manual vacuum aspiration was also done. Okay. So first was the first trimester MTP. So what are the methods we have? Is medical methods, suction and evacuation, that is surgical method, and other methods like menstrual regulation and manual vacuum aspiration can also be done. Okay. Now we'll see medical method of termination in first trimester. Now this can be classified according to the gestational age again. So up to 7 weeks, and then from 7 to 9 weeks. Okay. So we'll be using Mifepristone on day 1 at a dose of 200 microgram orally. Okay. So this is similar in both the cases. And on day 3, in the first category, that is up to 7 weeks, we'll be giving Misoprostol at a dose of 400 microgram. Okay. And in the second category, that is up to 9 weeks of gestational age, we'll be giving a dose of 800 microgram. So it is going to be Misoprostol. What is Misoprostol? Yes, it is prostaglandin E1, and it is 400 microgram here and 800 microgram here. Okay. Mifepristone dose is same. We will be giving Misoprostol on day 3 only, that is 36 to 48 hours after the Mifepristone dose. Okay. And Misoprostol can be given in various routes, like you can give it orally or you can give sublingually, you can give pervaginally or you can give per rectally also. Okay, the most effective route is sublingual route. Okay, but most common route is pervaginal route. Most commonly we will give it as a pervaginal dosage. Okay. When you give misoprostol, the products of conception will be expelled in another 4 to 6 hours. Okay. Sometimes there can be abdominal pain or cramps as a side effect. Okay. And if present, you can manage it with NSAIDs, that is non-steroidal anti-inflammatory drugs. And sometimes there can be excessive bleeding or incomplete abortion also. In these cases, there can be a need of surgical evacuation. Okay. And some of the other side effects of misoprostol include fever, vomiting and diarrhea. Okay. So, after performing medical termination of pregnancy, you have to advise them to review after 1 to 2 weeks. Okay. Mostly ultrasound examination may not be needed, ultrasonogram may not be needed, but you can perform a bimanual pelvic examination. Can be done. Okay. And what are the contraindications of performing a medical abortion in first trimester? See, there are so many contraindications. Suppose if the woman had already bled and she is already in a state of anemia, or if there is any heart disease or lung disease or a kidney disease or even respiratory disease, okay, that is compromising. And so in cases of uncontrolled hypertension also, okay, uncontrolled hypertension is there, okay, more than 160 by 110 millimeter mercury, and if you suspect it to be a ectopic pregnancy, okay, or she is on a steroid therapy, okay, lifelong, and when there is any allergic history to prostaglandins. Okay, so in all these cases, medical abortion in first trimester is contraindicated. Okay, so we can use surgical methods of termination of pregnancy up to 12 weeks. Okay, this is performed transvaginally. Okay, and in cases you have to give a preoperative cervical ripening. So that it will be facilitating easier dilatation of the cervix. So that will result in lesser pain to the patient, and also it will reduce the procedure time also. Short procedure time. Okay. Now we will see what are the agents we can use for cervical ripening. Number 1, we can use hygroscopic or osmotic dilators. Now these osmotic dilators draw water from the surrounding tissues and expands the cervix, resulting in dilatation. Okay, usually we can use laminaria or Dilation S. This Dilation S is a acrylic based gel. Okay. What happens is it will expand to 3 to 4 times of its original size. Okay. And there is also another problem with this. Suppose if you do a shallow insertion, it can lead to insufficient dilatation. And when you do a deeper insertion, it can lead to perforation. Okay. But when you keep these hygroscopic dilators, patient can void or she can move or she can pass tools without any limitations. Okay. And next one is, we can even use Misoprostol. We can give Misoprostol at a dose of 400 microgram orally or sublingually just 3 to 4 hours before the procedure. Okay. 400 microgram sublingually or orally, that should be given 3 to 4 hours before the procedure. Okay. We can also give Mifepristone at a dose of 200 mg 24 to 48 hours before the procedure. Okay. Now we will see the steps in suction and evacuation. First, empty the bladder. Okay. Then, place the patient in a lithotomy position. Then at this stage, perform a pervaginal examination again to know about the uterus, whether it is anteverted or retroverted, and even the size of the uterus also. Okay. Then you will do painting and draping. Okay. We'll use povidone iodine solution, and this painting should include the vagina and the cervix also. Okay. Next, we'll be placing a speculum. Okay. We can use some speculum, but it is not a self-retaining speculum. So, we can use this for posterior vaginal wall, and for the anterior vaginal wall, we can use an anterior vaginal wall retractor. Then, after placing that, anterior lip of the cervix can be grasped with a sponge holding forceps. Okay. And then we will be passing a sim sound to know the depth and inclination of the cavity. Then, if further cervical dilatation is needed, we can dilate the cervix by using Higa's dilators. Okay. Okay. Mostly Higgins dilators should be hold like how you hold your pen. Okay, just like this. Okay, you have to hold Higgins dilator just like this. So it is known as pen holding method. And degree of cervical dilatation in millimeters will correspond to the gestational age. Okay, in millimeters will correspond to the gestational age. Okay, and after this we can pass following this we can pass Corman's cannula of a appropriate size, okay, between 8 to 12 millimeter. Okay. Now at this time the cannula will be connected to the suction apparatus and the suction apparatus pressure will be maintained around 600 millimeter mercury. Okay. Will be connected to a suction apparatus and the pressure in the apparatus will be around 600 millimeter mercury. Now what we'll be doing is, we'll be slowly inserting the cannula through the internal cervical os and we'll be moving it till you feel the resistance. That resistance is the site where the fundus is present. Okay. As soon as you know the level of the fundus where it is present, we'll be moving the cannula sidewards and circumferentially and all, and you will be slowly drawing the contents downwards. Okay. So the cannula is pushed slowly into the uterine cavity till the fundus is reached. Okay, after that you have to do circumferential movements. Okay, that will be covering the whole of the uterine cavity. Okay, covering the complete uterine cavity and pull the contents downwards. And the content should be brought downwards. Now the aspirated contents are placed in a bowl of saline. Okay, by doing this, the blood clots, if any, will be removed. So this procedure is repeated until you see the bleeding has become less, okay, and the cannula contains air bubbles and there is a gritting sensation. And there is a gritting or a graping sensation. And after this, a check curettage can also be performed using the curette. A check curettage can also be performed. Okay, and sometimes there can be a need of serial monitoring by beta HCG, because if the pregnancy is less than 6 weeks, complete expulsion wouldn't be occurred. So what are the complications you can expect with this procedure? Complications may include uterine perforation, uterine perforation can occur while you are using dilators or the sound or Corman cannula. Okay, if the perforation had occurred due to dilators or the sound, okay, stop the procedure and observe the vitals. Okay. Suppose if the perforation has occurred due to Corman's cannula, okay, it can be understood that there is a sudden loss of resistance, okay, and the cannula can go anywhere, okay, including the fat, omentum, okay, and there will be a rapid fall in vitals, okay, rapid fall in vitals, especially rapid fall in BP and pulse rate, okay, and the patient may shout out of abdominal pain. There can be severe abdominal pain also, okay. So, in this case, you are going to resuscitate the patient, okay, resuscitate the patient, repeat. You will first resuscitate the patient by giving IV fluids, okay, and then perform an immediate laparoscopy or a laparotomy, okay, and don't forget to remove the instruments, okay, remove the instruments, and before shifting to the operation theatre, okay, if there is a need of shifting, then you can even keep the patient in cradle and work position. Clear? And during this procedure, a paracervical or a pudendal block can be given. Usually it is given at sites 4 o'clock and 8 o'clock position, okay. Remember not to give at the 3 o'clock and 9 o'clock position, because here the descending branches of the uterine artery are seen, okay. Descending branches of uterine artery are seen, okay. So, see here in this pic you are able to see at the 3 o'clock and 9 o'clock position, these are the descending cervical branches of the uterine artery, okay. So, this site we shouldn't touch. We can give anywhere in the 4 to 4 o'clock position or 8 o'clock position, okay. The other two methods of termination of pregnancy in the first trimester is manual vacuum aspiration and menstrual regulation, okay. So, this is a manual vacuum aspiration, aspirator, okay. So, in this, just like how we connect the cannula to the suction apparatus, we will be connecting the cannula here, okay, to the manual vacuum aspirator, and we will be giving a pressure, okay. So, here also the pressure can be created up to 600 millimeters of mercury, and it has a volume around 60 milliliter, okay. So, this is mostly done in situations when suppose the electricity is not available or in very rural areas, okay. And this is a menstrual regulation syringe, okay. Menstrual regulation, we are not at all doing it nowadays, okay. Previously it was done. Just to show you what is the difference between the manual vacuum aspirator and menstrual regulation, I have added here. See here, you have pinch walls, okay, but here you don't have pinch walls, and in the menstrual regulation syringe, it is just like a syringe and you have calibrations over here, but you don't see any calibrations in the manual vacuum aspirator, right. Now, we will pass on to the second trimester MTP methods. Again, you have medical and surgical methods. Okay. See, medical methods, you have no complications of anesthesia or surgery. Okay. Okay. So, the drugs you can use include prostaglandins, oxytocin, and theoretically it is extra amniotic ethacridin and intraamniotic saline. Okay. And remember the fact that Mifepristone is not approved for second trimester MTP. Okay. Okay. If we take prostaglandins, what is the most common prostaglandin we use? Yes, it is the prostaglandin E1 and it is known as Misoprostol. Okay, so we can use a dose anywhere between 200 to 800 microgram, and you can give it in any route. As I told you, it can be given orally or sublingually, okay, pervaginally or even perrectally, okay. But the most common dose we use is 400 microgram, and it has to be repeated every 4th hourly, okay, and you can use it up to 5 times. Clear? And what are the other prostaglandins that can be used? Means you can even use carboprost and dinoprostone. What is carboprost? It is PGF2 alpha. What is dinoprostone? It is PGE2. So, carboprost, that is PGF2 alpha, and dinoprostone, that is PGE2, can also be used. But among this, prostaglandin E1, okay, that is misoprostol, has a high success rate. Okay, and while using oxytocin for second trimester MTP, you can use it as a high dose, okay, and via IV infusion, okay, and 80 to 90% chance of success is seen with oxytocin, okay. And if we take the surgical methods, now if we take ethacridine, it is an organic antiseptic, okay. So, that activates the myometrial mast cells to bring about the contraction, okay. And how this contraction is brought means, again there is release of prostaglandins, okay, inside the myometrium, okay. It is mostly given intraamniotically, okay, but there is a longer duration for the process and there is lower success rates, okay. So, we are not using this procedure anymore, okay. And when you take dilatation and curettage, see, dilatation and curettage is similar to suction and evacuation. Okay, what we'll be doing is, instead of connecting the cannula to a suction apparatus, okay, we'll be just evacuating the uterine cavity by using a ovum forceps. Okay, we'll be catch holding of the products of conception using a ovum forceps and we'll be slowly remove it. Okay, and it also can be done using a sponge holder. So, similar to suction and evacuation, all the steps will be similar, okay. So, all the steps are similar except that you are not connecting it to a suction machine and you will be using a ovum forceps or a sponge holder to collect the products of conception, okay. To remove and collect the products of conception. Okay, and after completing this, you will be going for a blunt curettage also. Okay, that is a cheek curettage. And with surgical procedures, there are so many disadvantages. As we have already discussed, there can be chances of perforation. There are some other surgical complications also. We'll discuss that here. So, surgical complications. Already we have seen about perforation, uterine perforation, Then there can be genital tract laceration. Okay. When you do a sharp curettage, okay, that's why I was stressing upon blunt curettage. If you do a sharp curettage, then there can be chances of Asherman syndrome also. Okay, that means formation of uterine synechiae. Okay. Next, there can be risk of hemorrhage, infection, and sometimes there can be incomplete evacuation also that will result in re-evacuation. Okay. Now, as I have talked so much about the various instruments that are used in dilatation and curettage, I am very sure that you might be confused about the instruments. So, let's have a glance about some of the instruments that are used in dilatation and curettage. Okay. So, the first instrument is a SIM speculum. Okay. Remember, this is a non-self-retaining speculum. That means you need one person to hold this. Okay. And if you are doing it alone, you can't use it for both anterior vaginal wall and posterior vaginal wall. So, for anterior vaginal wall retraction, you can use a anterior vaginal wall curette. Okay. So, if you see the parts of this instrument, you have concave blades, you have a shaft. Okay. And the next instrument is cuscospiculum. Okay. So, here you have a anterior blade, you have a posterior blade, and you also have a fixation screw. Okay. And the advantage of using cuscospiculum is it is a self-retaining speculum. Clear? Now, the next instrument is valsalum. Okay. You can hold the anterior lip of the cervix in dilatation and evacuation or suction and evacuation. Okay. Holds the cervix in dilatation and evacuation. And the disadvantage is it produces trauma. Okay. So, most of the times we will not be using a valsalum. See, the instrument is a curved instrument, okay, with toothed ends. Can you see? There is a sharply toothed edges, okay. And if you see this long instrument that is curved like this, okay, then it is valsalum. Next one is uterine sound. So, if you see, this is a pointed instrument, okay. It is graduated, means it has markings on it and it is usually made of metal. Okay. So, this is the first instrument that you are going to pass into the cervix to know the length of the uterus. Okay. So, basically it can act as a dilator also. Acts as a dilator also. Okay. So, we will be assessing the length as well as position of the uterine cavity by using a uterine sound. Yes. Next is a sponge holding forceps. Okay. See, basically this is used for toileting the vulva, vagina and perineum prior to any procedures and even prior to natural labor. Okay. Prior to any gynec procedures or obstetric procedures or even delivery. Okay, and in dilatation and evacuation, we'll be using it to catch hold of the cervix also in dilatation and evacuation. Okay, and this one is ovum forceps. Okay, so if you see, the ends are spoon shaped. Okay, so it is a spoon shaped forceps. It will be introduced into the uterine cavity with the blades closed. Okay, and then you will be catch hold of the products of conception and you will be trying to take it out. Okay, so introduced with the blades closed into the uterine cavity. Okay, then again it will be opened up to grasp the products. Okay, opened up in the cavity to grasp the products. So this is a curette. Okay, it has one end to be, say this is a sharp end and one end can be blunt end. Okay, and usually we perform check curettage with blunt end only to avoid Asherman syndrome. And also another thing is, in if you are performing MTP, in that dilatation and evacuation is performed, the uterus will be very soft during pregnancy. Okay, so we'll avoid the sharp end. So these are Heger's dilators. Okay, there are so many calibrations of Heger's dilators and it will be usually given in mm. Okay, for example, if you have a 8 mm Heger's dilator, it will be equal to the corresponding gestational age. That means 8 mm Heger's dilator for a 8 weeks of gestational age. Okay, and if you want to do dilatation and evacuation for a 10 weeks of gestational age, you can take a 10 millimeter of Heger's dilator. Okay, so these are the Corman cannulas. Okay, these are soft and flexible cannulas made of plastic. So I hope you would have understood about the medical termination in pregnancy, what are the various methods and how you will be doing it in the first trimester, second trimester, what are the surgical methods, what are the steps in surgical methods, and also about the MTP Act. And we have discussed some of the instruments also. So with this, we'll finish this video. Until we meet in the next video, happy learning, take care and bye-bye.